The topic of my presentation is trauma in women with substance use disorder. So I wanted to introduce my talk today by bringing in two quotes from the book The Body Keeps the Score by Bessel van der Kolk. And if you haven't read this book, it's a fantastic book. I highly recommend it. A lot of my presentation is based off of his work and other leading trauma researchers in the field. So the first quote I wanted to use to lay the foundation of this presentation, he writes, "Trauma is the ultimate experience of this will last forever." So imagining something terrifying or horrifying happening to you and having that feeling that this will last forever, of course, is something we'd want to prevent for any human being. The second quote I pulled was, "Trauma invariably involves not being seen, not being mirrored, and not being taken into account." So I hope this presentation will help us take that step forward in helping people who are not feeling seen and not being taken into account to hopefully have them feel like what happened to them will not last forever. So some of the questions that I want to address today, I want to talk about the difference between trauma, acute stress, post-traumatic stress, and complex post-traumatic stress. They're all a little bit different. I want to talk about why women are at higher risk for experiencing trauma and why women are at higher risk for developing comorbid PTSD and substance use disorder. I also want to talk about how closely linked PTSD and substance use disorder are, and what might trauma symptoms or PTSD symptoms look like in women with substance use disorder. So we know that there's a spectrum of response to potentially traumatic experiences. And the reason I say potentially traumatic experiences is because we know that you could have the exact same thing happen to two people on the exact same day in the exact same way, and they might have completely different reactions. So what one of us thinks would certainly be a traumatic experience might not be for the person sitting next to you. So that's why I added that word, potentially traumatic experience. So like I mentioned, there's a spectrum of responses. So many trauma survivors experience symptoms that might not meet the diagnostic criteria for acute stress disorder or PTSD, but they would still experience difficulty with different things, such as regulating their emotional states, maintaining steady and rewarding social and family relationships, performing competently at a job, or maintaining a steady pattern of abstinence and recovery. So these symptoms can be transient, they can be intermittent, or a part of the individual's regular pattern of functioning. And often these symptoms that I mentioned, or these patterns, are termed subthreshold trauma symptoms and can be misdiagnosed as depression, anxiety, etc. So I want to lay that as a foundation that just because someone might not have a formal diagnosis of PTSD or complex PSD or ASD or whatever, doesn't mean that they might not be struggling with these different things due to a potentially traumatic experience. So when we're talking about acute stress or acute stress disorder, this represents a normal response to stress. Symptoms typically develop within 4 weeks of a traumatic experience and can cause significant levels of distress. Most individuals who have acute stress reactions never develop further impairment or a further diagnosis of PTSD. And acute stress disorder is highly associated with the experience of one specific trauma rather than the experience of long-term exposure to chronic traumatic stress. So, for example, it's more likely a single car accident would cause acute stress disorder versus chronic childhood abuse is more likely to contribute to chronic traumatic stress or complex PTSD. However, the diagnosis of ASD can change to a diagnosis of PTSD if the symptoms do persist past 4 weeks. And there is some suggestion that, as with PTSD, acute stress disorder is more prevalent in women than in men. So when we're talking about post-traumatic stress and PTSD, essentially this is where individuals must have been exposed to actual or threatened death, serious injury, or sexual violence, and the symptoms must produce significant distress and impairment for more than 4 weeks. So the 4 symptom clusters for PTSD is a presence of intrusion symptoms, that could be flashbacks or nightmares, persistent avoidance of stimuli, so not going to a certain parking lot where something might have happened, for example, or even avoiding a road that leads to that parking lot. negative alterations in cognitions and mood, and marked alterations in arousal and reactivity, hyperarousal and hypervigilance, etc. So when we're talking about complex post-traumatic stress, research has shown that individuals are more likely to have a history of exposure to several traumatic events rather than one single trauma. So in addition to standard PTSD symptoms, complex trauma can impact the following domains, again, in addition to standard PTSD symptoms. So that includes affect, attachment, behavior, biology, cognition, perception, self-image, and academic functioning. So complex PTSD, like I mentioned, includes the core symptoms of PTSD in addition to a range of difficulties in self-regulatory capacities. So whether that's emotion regulation, relational capacities with other people or family members, alterations in attention and consciousness, such as disassociation. This is why dissociative identity disorder is commonly found in populations that have experienced trauma. Adversely affected belief systems, so feeling like the world is no longer a safe place, and somatic distress or disorganization. So complex post-traumatic stress is almost always the result of exposure to repeated or prolonged instances or multiple forms of interpersonal trauma. So it's less likely that this would be due to a hurricane or natural disasters, but more likely that interpersonal component with other people, more likely people that that people trusted or were supposed to take care of them. It often occurs under circumstances where escape is not possible due to a multitude of factors, whether it's physical, psychological, developmental, environmental, or social constraints. And it can include childhood physical or sexual abuse, recruitment into armed conflict as a child, being a victim or survivor of domestic violence or sex trafficking, experiencing torture and exposure to genocide or other forms of organized violence. So again, that's more of that interpersonal trauma and repeated or chronic. So the symptom profile of complex PTSD recognizes the loss of emotional, social, cognitive, and psychological competencies that either failed to develop properly or that deteriorated due to prolonged exposure to complex trauma. And complex PTSD is relatively new in the research compared to PTSD. There's been a movement towards looking at these and splitting these two different types of traumatic experiences. Like I mentioned, having one acute thing happen to you versus chronic childhood abuse, and seeing different presentations in these different types of trauma. So currently the most common diagnoses associated with trauma are PTSD and ASD. However, trauma is also associated with the onset of a variety of other mental disorders, such as substance use disorders, as we know, mood disorders, various anxiety disorders, and personality disorders as well. So we know that trauma typically exacerbates the symptoms of pre-existing disorders, and it can occur almost simultaneously with trauma exposure, or it can manifest sometime after, sometimes even several years after as well. So when we're talking about women in trauma, I pulled another quote from The Body Keeps the Score. It reads, "Being able to move and do something to protect oneself is a critical factor in determining whether or not a horrible experience will leave long-lasting scars." So I think this is a really helpful piece to look at when you're working with clients with traumatic, potentially traumatic experiences is, were they trapped? Did they have an utter loss of control, which I think, unfortunately, is likely in situations of sexual violence surrounding both sexes, but women in particular. So early experience with trauma, such as a history of childhood sexual or physical abuse, like I mentioned, heightens a person's susceptibility for severe PTSD symptoms as an adult. And then in addition, victims or survivors of childhood abuse are at a higher risk for developing PTSD symptoms following other traumatic events in adulthood that might be completely unrelated to what they experienced throughout childhood. So again, talking about women in trauma, it's important to consider sexual violence experiences in differentiating between PTSD and complex PTSD, with sexual violence more often being associated with complex post-traumatic stress disorder. So when we're talking about comorbid substance use disorder and post-traumatic stress disorder in women, research has shown that the association between PTSD and alcohol use disorder is particularly strong for women. A history of sexual abuse can increase the risk of problem drinking up to 20 times the normal rates of alcohol use, and this is for both sexes. However, it was found that females were much more likely to have been sexually abused than males, and therefore the symptoms of PTSD were more commonly seen in females than males with alcohol use disorder specifically. In adults, the rates for comorbid PTSD and substance use disorder are 2 to 3 times higher for females than for males, with 30 to 57% of all female substance abusers meeting the criteria for PTSD. That's in one research study. And women compared to men were more than twice as likely to meet criteria for both post-traumatic stress disorder and for complex post-traumatic stress disorder. Like I mentioned, cumulative childhood interpersonal violence was a much stronger predictor of complex post-traumatic stress disorder than of PTSD. And it was associated with greater comorbid symptom burden and also substantially lower psychological well-being. So I think it's really important to, when you're working with clients or patients, to take a closer look at the different symptomology between complex PTSD and PTSD. So as I mentioned, a wide body of research has shown high rates of comorbid PTSD and substance misuse. The alleviation of the negative affect might be one motivation for individuals with substance use disorder and PTSD to continue using substances. And another research study has shown that substances, including alcohol and benzodiazepines, are associated with memory impairments, which supports the idea that some people might use drugs to facilitate dampening and forgetting of traumatic memories, as we discussed in our case discussion. So this emotional numbing concept is not simply avoidance that provides protection against painful or negative emotions, but it's actually an inability to feel both negative and positive emotions. And this is a result of the emotional exhaustion that can take place due to the prolonged hyperarousal that individuals with post-traumatic stress might experience. Individuals with comorbid PTSD and substance use disorder report increased craving for alcohol and cocaine following exposure to personalized trauma cues, and that's in the absence of cues related to drugs and alcohol. And as we know, personalized trauma cues can be so small, appearing out of nowhere, and sometimes it can be hard for anyone to pinpoint down what that might be or what that trigger might be. So I think that's an important note, that those trauma cues can really contribute to the increased craving. So this supports the importance of looking at those trauma-related memories in ongoing drug use. So some additional research studies showed that prior PTSD compared with individuals with no trauma history has been associated with a 4.9 time increase risk of emergence of substance use disorder, and this is after controlling for common risk factors, including childhood conduct problems or behavioral problems, risk-taking behaviors, and the family's socioeconomic status. A large body of evidence has supported the role of stress in both the initiation and the maintenance of drug use behavior. So for example, in animal studies, induction of physical or psychological stress was shown to facilitate both the initiation of drug self-administration in the animals, and it facilitated relapse to drug use as well. So there's one hypothesis called the endorphin compensation hypothesis, which is where people use alcohol following a traumatic experience in an attempt to relieve the endorphin deficiency. So when something traumatic happens to you, a significant release of endorphins occurs. And then in a period following that traumatic experience, there's a deficiency of endorphins. So this is one hypothesis that people might use alcohol to kind of make up for that deficiency. So the use of alcohol creates a cycle where more alcohol is needed to prevent that subsequent endorphin withdrawal symptomology. Special populations such as women, which we're talking about today, may be at particular risk for this trauma-induced co-occurring SUD and PTSD. So self-medication or substance use or abuse is one of the methods that traumatized people also might use in an attempt to regain that emotional control, although ultimately it usually causes even further emotional dysregulation. And this can provide a false and paradoxical feeling of control that was absent during that traumatic experience. So the relationship between PTSD and SUD is thought to be both bidirectional and cyclical, in where substance use increases the trauma risk for experiencing potentially traumatic experiences, and also the exposure to trauma can escalate substance use to manage those trauma-related symptoms. So when we're talking about symptoms of trauma in women with substance use disorder, what you might see when you're working with clients or patients, when something reminds a traumatized person of their past or the past traumatic experience, the right brain typically can react as if the traumatic event is happening right now in the present. And because their left brain is not currently active at that moment, they might not be aware that they are reenacting the past or refeeling their past experience. Just in the moment, they are furious, or terrified, or enraged, ashamed, or frozen, and they might not know why. So that's something to keep an eye out for and recognize that you might be seeing that in your population. And when that emotional storm passes, the individual might look for something or someone else to blame for that turbulent emotions, or believe that their reaction was triggered by someone else's behavior. So one more quote from The Body Keeps the Score. As long as the trauma is not resolved, the stress hormones that the body secretes to protect itself keep circulating, and the defensive movements and emotional reactions keep getting replayed. They have no idea why they respond to some minor irritation as if they are about to be annihilated. And I thought this was really helpful in working with people at work or even in your day-to-day life, noticing that some minor irritations might really escalate a person. This is just something to keep in mind in terms of, as I'm sure we've all heard, looking at trauma as what has happened to you versus what's wrong with you. So another research study showed that undergoing detox without diagnosis and management of post-traumatic stress disorder symptoms might result in a cycle in which those PTSD symptoms, which were controlled by substance use, return again when the individual is drug-free and perpetuate a relapse. In a 2004 study, it was found that trauma memories were reported as becoming more vivid after ceasing drug use by 61.7% of the sample. 61.3% of the sample reported experiencing an increased frequency of trauma memories, and 38.2% reported that trauma memories become more distressing after stopping drugs. So I think that alone is huge in considering when we're working with individuals in substance use treatment or recovery, and in taking a look at potential trauma memories that might be impacting their recovery. Trauma often occurs under conditions of no personal control, as I mentioned previously, and individuals who have experienced these traumatic events may subsequently attempt to overcompensate by being in control of as many aspects of their life and experience as possible, which makes sense and why it's really important to, as a provider when you're working with survivors of trauma, to be really aware of not taking away control from that person, and really giving control back to them in as many ways as you can. That can really be tremendously helpful when working with survivors of trauma. So in terms of, again, seeing trauma in women with substance use disorders and treatment settings, there's a risk of misinterpreting trauma-related symptoms in substance abuse treatment settings. So for example, you might see avoidance symptoms that is more likely related to post-traumatic stress, but it can be misinterpreted as a lack of motivation or an unwillingness to engage in treatment. Efforts to address substance use or abuse-related behaviors in early recovery periods can sometimes provoke an exaggerated response from a trauma survivor who has profound traumatic experience of being trapped and controlled. So again, there's that concept of that lack of control, and how can we provide that back to our patients or clients whenever possible. Some clients in recovery might only begin to experience those trauma symptoms when they maintain abstinence for some time. So as they decrease their tension reducing or self-medicating behaviors, such as using substances, those trauma memories and symptoms can emerge. So it's really important to keep in mind, essentially keeping in mind that the traumatic memories and symptoms that might be emerging while you're working with individuals that are moving towards recovery. And a lot of this information I want to mention was pulled from the SAMHSA's Tip 57, which I highly recommend as well. If you haven't taken a look through that, if you just Google that, you can find it. And I highly recommend the information in that document as well. So I know a lot of this is really heavy. It's hard to think about, hard to talk about. So I want to encourage everyone to look up some research on post-traumatic growth and resiliency. I didn't have time to cover it in my presentation today, but there's some new research and some pretty positive research on both of these topics that I recommend you take a look at if you're interested. Another resource is the resiliency quiz, which you could take for yourself in a work setting or a personal setting, pass it on to colleagues, or even use it with clients or patients to identify some protective factors that might be in your life and different resiliency components that you have to rely on in times of difficulty. So I also wanted to put a plug for my trauma-informed care treatment presentation, which is coming up in January, which hopefully will address, which will be the next step in talking about what are some ways that we can work with individuals in treatment that are survivors of trauma. So I think I have enough time for questions.
Yeah.
This is Miranda Banky from Libertas and Marinette. Great job, by the way.
Thank you.
You're welcome. I'm wondering, are you okay if I can share this with the rest of our colleagues here?
Yeah, absolutely. Yep. And I'd be more than happy to pass along if there's specific studies in there that that you're interested in. I took a trauma counseling course, so I have all of the content, and I'd be happy to scan that and email it to you or anything. So let me know if there's specific studies or resources in there that you want me to send you as well.
Will do. Excellent. Thank you.
I found this really interesting too. We just finishing up a study, STOMP, Screening and Trauma for Opioid Misuse Prevention, where we recruited 295 patients from trauma and orthopedic inpatient services and followed them forward after discharge for 6 months.
Okay.
And then we're following a number of things, but primary thing we were looking at was misuse of their prescription opioids or progression to an actual use disorder. And as we were really sort of drilling down into the things that most strongly predicted misuse of their opioids or development of a use disorder, it was this stuff.
Yeah.
Like trauma, sort of anxiety related symptoms, like coping with pain, coping with stress, were really the things that seemed to be driving it. So definitely good for us to have on our radar, and good to see, that folks that are providing care with people with use disorders, that this is really getting to be being on the radar a lot, right? I mean, this is part of the dialogue.
Yeah. And I think it's really helpful to look at substance use as a really strong coping mechanism for survivors of trauma. That's a lot to carry. That's a huge burden. And so I think reframing it in that way, like, look at all the things that you've been able to survive, and all the coping skills that you've gathered, whether we think it's healthy or not. Right? I think that can be a more helpful way to look at it.
Right.
And actually, to extend that, we do a lot of work with the nations. So then add historical trauma, and at that point, substance use disorder becomes a symptom of the epigenetics of historical trauma. It completely changes the framework around it, and it makes a big difference.
Right.
Yeah.
Right.
There's a lot of interesting research on that topic as well.
Yeah.
Yes.
Yeah, the Department of Health Service just put on a very nice presentation on historical trauma up at the Red Cliff Tribe up here.
Oh, wow.
It was very, very interesting.
Yeah.
You don't know that that's content that's publicly available, do you?
I think it probably would be if you contacted the Department of Health Services.
DHS, yeah.
And if you want to take it a step further, Dr. Brown, we had contact with our doula training that was done mostly with women from the nations and from the communities. We had two trainers. One was Doreen Day, and she is nationally, internationally recognized, spends a lot of time in Canada. But she not only speaks to historical trauma, she of course speaks to cultural humility and cultural responsiveness. And one of the needs that we have identified is there needs to be training in this for healthcare.
Yeah.
Covington has out her from trauma informed to trauma responsive, which is a good program. But we as westernized healthcare do a terrible job with our care for people from these communities. And we don't even recognize all the things we do that just constantly re-traumatize. So this is a huge, huge need.
Yeah. This is starting to feel like a didactic that we should be looking for down the road.
And Doreen is willing to do something like
I second that.
Great.
I wonder, do they have like a trauma survey like they do with the youth risk behavior survey that we can administer? Just thinking as a public health nurse, I think big picture and wanting data moving forward in my funding and my programming, that might be kind of helpful.
So you're asking about like screening tools,
Right.
Clinical practice?
Right.
So there are a variety. A couple that I see in practice quite commonly are, of course, the adverse childhood experiences questionnaire, and then something particular to PTSD symptoms that's fairly manageable in primary care settings is the PCL5, or the primary care PTSD.
There's another one out on the SAMHSA integration website, and it's lifetime. I forget, I can send that later to be forwarded, but it looks at lifetime events and whether you were the focus of it, you witnessed it, you heard about it. There's all those different levels to it. And what we liked, we moved on from the ACEs to this, is because it looks at the full lifetime versus just the ACEs is so child specific, and we understand that, but we felt there was benefit in this as well, particularly since we see a fair number of people who are impacted by others' trauma as well. So
right, secondary trauma for
yeah,
sure.
so SAMHSA has that out on their integration website.
And there's an even briefer particular to PTSD screen that's actually only 2 items. I believe it's called the PCL2. It's been validated primarily in veteran samples, so the extent to which it's generalizable to primary care settings would be a question. And I'm forgetting which 2 items particularly they pull from that, but that's another one that's out there and in fairly wide practice, but again, primarily at VA.
Yeah, we just got our youth risk behavior surveys back, and it was kind of disturbing at our ratios for kids in our county who have had suicidal thoughts, and then the ones that have made a plan. So the difference between the kids who had suicidal thoughts and the ones that actually made a plan was only 2%. So, and there's also a lot of substance abuse, and I'm, try to come at that from a trauma perspective, going, what is going on? And, I curtail my community health education events and things towards these subjects and try to bring trauma-informed care to the public, not just healthcare workers, so that they know how their actions are affecting the kids and their kids' health.